This is A&P Live Studio. I am your host. I teach A&P as a registered nurse and anatomy and physiology instructor for advanced healthcare professionals. Today we're going to explore the critical link between sleep, neuroplasticity, and memory, and we'll do it by examining a clinical case that brings all these concepts together.
This is what our patient, Pepe, told us. It's a complaint we hear a lot, right? But it points to something much deeper. A significant disruption in her brain's fundamental ability to learn and hold on to new information. So let's take a closer look at our case.
So, Pepe is a 22-year-old college student, and she's come to the clinic with this brain fog and a noticeable drop in her academic performance. Here's the key detail. Even though she's spending a full 7 to 8 hours in bed, she feels completely unrested. This non-restorative sleep is also coming with muscle aches, a real struggle to remember things she's just studied, and a shrinking attention span. Her case is really a classic example of how sleep dysfunction can present itself as cognitive decline.
To really understand what's happening with Pai, we're going to first look at how memory is supposed to work. Then we'll see how sleep loss completely breaks that process, and from there we'll walk through the diagnosis, the treatment, and the ripple effects this has on the rest of the body.
Okay, let's start with what I like to call the brain's overnight filing system. Before we can get into the pathology, we have to have a solid grasp of the normal physiology. You see, memory isn't just a static recording. It's an active, dynamic process that's rooted in the brain's amazing ability to physically rewire itself, a concept we call neuroplasticity.
So, when we zoom all the way down to the cellular level, the fundamental mechanism for learning is something called long-term potentiation, or LTP. A good way to think of it is like turning up the volume on a conversation between two neurons that talk to each other a lot. When one neuron repeatedly activates another, that connection, the synapse, gets stronger and more efficient. This is the actual biological basis of a memory trace.
And here we can see the really elegant molecular dance that makes LTP possible. It all starts when the neurotransmitter glutamate is released from the presynaptic neuron. If that signal is strong enough, it physically kicks a magnesium ion out of the way that's been blocking the NMDA receptor. This opens up the channel, and boom, calcium ions flood into the next neuron. This calcium influx is a powerful second messenger. It triggers a cascade, activating enzymes that then shuttle more AMPA receptors into the synapse. More receptors mean a stronger response to future signals, and that's the core of a strengthened connection.
Now, on a bigger scale, at the organ level, the hippocampus is really the star of the show for new declarative memories. It works like a temporary hub, or maybe a scratch pad. It binds together all the different parts of an experience, what you saw, what you heard, how you felt, into one cohesive memory. But here's the catch. The hippocampus has limited storage. It was never meant for permanent filing.
And this is exactly where sleep becomes absolutely critical. During non-REM sleep, your brain is busy performing what we call systems consolidation. It's literally moving memories from that temporary hub in the hippocampus to the long-term archives of the neocortex. And this whole process is orchestrated by this beautiful symphony of 3 specific brainwaves. You've got the slow oscillations in the neocortex acting as the conductor. Then you have sleep spindles, which drive the actual transfer. And finally, you have these high-frequency hippocampal ripples, which are like a high-speed replay of the memories being moved. It is the brain's perfect overnight filing system.
So, what happens when this incredibly intricate filing system gets disrupted? Let's get into the core pathophysiology now to see exactly how this all breaks down in conditions like insomnia and sleep apnea.
One of the key players here is a molecule called brain-derived neurotrophic factor, or BDNF. You can think of it as fertilizer for your neurons. It supports their health and promotes that plasticity we talked about. Now, what's interesting is that a single all-nighter might actually cause a temporary spike in BDNF, probably as part of a stress response. But chronic sleep disruption, the kind Pai is going through, does the opposite. It leads to a consistent decrease in BDNF, essentially starving the brain of a molecule it desperately needs for memory.
All right, let's look at the 2 most common culprits here. With chronic insomnia, the brain is essentially stuck in a state of hyperarousal. This fragments your sleep architecture and constantly interrupts that vital conversation between the hippocampus and the neocortex. Now, with obstructive sleep apnea, or OSA, you get a double whammy. You have the sleep fragmentation, but you also have intermittent hypoxia. These repeated drops in blood oxygen actively damage neurons, they impair synaptic function, and they reduce cerebral blood flow. It's a direct assault on the cellular machinery of memory. And this really shows the downstream consequences perfectly. When you have low BDNF and repeated hypoxia, that molecular cascade for LTP we just talked about, it just fails.
The overnight filing system, that systems consolidation, it breaks down. This leaves memories vulnerable and essentially stuck in the hippocampus. And because the hippocampus never gets cleared out, its ability to encode new information the next day is severely compromised. It's like trying to work on a computer when the RAM is completely full. And on top of all that, reduced cerebral blood flow starves the brain of the oxygen it needs to do any demanding cognitive work.
So now, let's tie this all back to Pepe's symptoms. Her brain fog and slowed thinking, those are a direct result of that decreased cerebral blood flow and poor synaptic function. Her falling grades, that's failed systems consolidation. The information from her classes never made it into long-term storage. Her poor attention span, that's because of the full hippocampus, which just can't efficiently take in new learning. Even her muscle aches can be explained by the systemic inflammation and lack of physical restoration that's supposed to happen during deep, restorative sleep.
Okay, so how do we actually confirm the diagnosis and figure out if we're dealing with something like insomnia versus sleep apnea? The diagnostic process has to be systematic, and the goal is to pinpoint the exact nature of the sleep disruption.
Well, the clinical history is always first and it's paramount. Asking questions about snoring or if anyone has witnessed pauses in breathing, that points us towards sleep apnea. Trouble falling asleep or staying asleep suggests insomnia. A neurological exam is also important to get a baseline for any cognitive deficits. But the gold standard for diagnosing sleep apnea is polysomnography, the overnight sleep study. It gives us objective data by directly measuring brain waves, oxygen levels, and breathing, so we can actually see the sleep fragmentation and hypoxia. Finally, some basic labs like a CBC and TSH are crucial to rule out other things that could cause these symptoms, like anemia or a thyroid issue. Once we have a clear diagnosis, the goal is simple: restore normal sleep physiology. And the treatments we use are targeted directly at fixing the underlying pathophysiology we've been talking about. Now, for chronic insomnia, the first-line treatment isn't a pill. It's cognitive behavioral therapy for insomnia, or CBTI. It's designed to address the maladaptive thoughts and behaviors that are keeping the person from sleeping. For obstructive sleep apnea, the gold standard is continuous positive airway pressure, or CPAP. This device basically acts as a pneumatic splint to keep the airway open all night.
Let's look at exactly how these work to restore brain function. CBTI works by calming down that state of cognitive hyperarousal. By restoring sleep continuity, it gives the brain the uninterrupted time it needs for that systems consolidation process to work properly. CPAP, on the other hand, is a direct mechanical fix. By preventing the airway from collapsing, it eliminates the intermittent hypoxia and the sleep fragmentation it causes. This restores normal blood flow to the brain and allows synaptic function to recover, creating the perfect physiological conditions for memory consolidation to get back on track.
It's so important to remember that the brain doesn't operate in a silo. The consequences of disordered sleep create ripples that spread throughout the entire body.
Of course, the nervous system is the primary site of injury here, but the cardiovascular system is also taking a direct hit, especially in sleep apnea, which significantly increases the risk for hypertension and stroke. The endocrine system gets dysregulated too, altering cortisol and growth factor levels that impact both metabolism and neuroplasticity. And, just like we saw with Pepe, the muscular system suffers from impaired repair processes, which leads to that feeling of myalgia.
Just a quick note on genetics. It's true, there are genetic factors that can make someone more prone to insomnia or sleep apnea. However, the cognitive symptoms we see in a case like Pepe's are a direct result of the pathophysiology of her sleep disruption, the hypoxia, the fragmentation, the hyperarousal. It's not a separate genetic issue causing her memory loss.
And this isn't some rare, obscure problem. We're talking about an estimated 50 to 70 million adults in the United States who have a sleep disorder. What this means is that as clinicians, you will absolutely encounter patients whose main complaint is cognitive decline, when the root cause is actually disordered sleep.
So to wrap this all up, new memories are solidified during sleep through systems consolidation. Sleep disorders like insomnia and sleep apnea break this process through mechanisms like hyperarousal and hypoxia, which leads to the brain fog and memory issues we saw with Pai Pai. By treating the sleep disorder, we restore the brain's ability to maintain itself. The big takeaway here is that memory isn't a passive filing cabinet, it's an active, dynamic biological process that demands constant maintenance, and quality sleep is one of its most essential requirements. This video is for educational purposes only and is not intended as medical advice, diagnosis, or a substitute for professional healthcare decisions. Stay pathocurious and see you next episode.